Welcome to the deep dive. Today, we're venturing a bit off the beaten path, moving beyond the typical carotid artery disease we often discuss.
Right. Atherosclerosis gets a lot of attention, and for good reason, but it's definitely not the whole story when it comes to the carotids and brain health.
Exactly. There's this whole spectrum of rarer conditions, sometimes quite unusual ones, that can still have a significant impact.
Absolutely. Things people might not have heard much about.
So that's our focus today. We're going to explore things like carotid body tumors, carotid sinus syndrome, which is a peculiar one, moya-moya disease, and even physical changes like carotid artery kinks and coils.
And we should probably also touch on some related intracranial issues, like certain stenoses and aneurysms, because they often tie in.
Good point. We need to stress, though, that while these are less common than your standard plaque buildup, they aren't trivial. They can seriously affect brain health.
Definitely. They present unique challenges.
And for our guide on this, we're leaning heavily on the latest insights from Rutherford's vascular surgery and endovascular therapy, the 10th edition, a real authority.
Can't get much more authoritative than Rutherford's.
Our mission, really, is to pull out the key takeaways from those chapters, give you a solid understanding of these less common carotid issues, maybe share some surprising facts, but, keep it clear and focused on what really matters for cerebral health.
Sounds like a plan. Where should we start?
Let's kick off with carotid body tumors. What exactly are these?
Okay, carotid body tumors, or CBTs, these are pretty rare neoplasms. They're highly vascularized, meaning they have a rich blood supply.
And they grow from specific cells.
Yes, they originate from neural, crest-derived chemoreceptor cells, specifically the glomus type I-chief cells, which are located right at the carotid bifurcation.
Ah, the spot where the main carotid artery splits.
Precisely. You might also hear them called carotid glomus tumors or glomus caroticum. Technically, they're extra-adrenal neuroendocrine neoplasms.
Extra-adrenal, meaning outside the adrenal glands, but still hormone-related, given they're from chemoreceptor cells.
Exactly. These cells normally sense chemical changes in the blood, like oxygen levels, so the tumors arise from that specialized tissue. They're not your everyday neck lump.
So how often do these actually, pop up?
They're quite uncommon. Incidence is estimated somewhere between, say, 1 in 30,000 to maybe 1 in 100,000 people.
And are there patterns? Like, who gets them?
Well, they seem to be a bit more prevalent in women. And interestingly, they can be bilateral, appearing on both sides of the neck in up to maybe 25% of cases.
Wow, bilateral in a quarter of cases. That's significant.
It is. And there's a strong familial link, too. About 30–40% of cases seem to run in families.
That high. So if you have a family history, is that something doctors look out for more proactively, maybe earlier screening?
That's a great point. There aren't formal screening guidelines just based on family history, but it certainly raises awareness. If a relative had one, it's worth mentioning to your doctor. Oh, and another factor, there's a higher incidence in people living at high altitudes.
High altitudes? Huh. Any idea why?
The thinking is it might relate to chronic low oxygen levels stimulating those chemoreceptor cells over time.
Makes sense. So how would someone know they have one? What are the symptoms?
Often they start out asymptomatic. Someone might just notice a painless lump or a feeling of fullness in the neck, usually around the level of the hyoid bone.
But they don't stay small and quiet forever, presumably.
No. As they grow larger, they can start pressing on nearby structures, especially cranial nerves. We're talking the glossopharyngeal, vagus, hypoglossal nerves.
Which control things like swallowing, voice.
Exactly. So symptoms can include things like Horner syndrome, maybe vocal cord paralysis causing hoarseness, pain in maybe 10–20% of cases, difficulty swallowing, that's autoanaphagia or dysphagia, noisy breathing or stridor, even cough or tinnitus.
That sounds like it could really impact quality of life. Any other signs?
Sometimes tenderness in the area, dysphonia, just changes in the voice. What's interesting is that things you might expect with artery problems, like a whooshing sound, a bruit, or palpable thrill, they're actually atypical with CBTs.
Okay, so don't expect the usual vascular signs. What about that Fontaine sign mentioned in the notes?
Ah, yes, Fontaine's sign. In slender patients, you might notice the mass seems fixed vertically, but you can move it side to side, horizontally. It's because of its attachment right at the bifurcation.
Does that specific movement pattern tell you something important, like confirming it's likely a CBT?
It's quite suggestive, yes. That specific mobility pattern points towards its origin at the carotid bifurcation. And rarely, these tumors can be functional.
Functional meaning they produce hormones.
Exactly. They can release substances causing sympathetic hyperactivity, thinking headaches, fast heart rate, high blood pressure, palpitations, but that's uncommon.
The big question with any tumor, are they cancerous?
Fortunately, the risk of malignancy is low, generally cited around 5%.
Only 5%. That's reassuring.
It is. But because there's always that possibility and the potential for tiny microscopic spread, any suspicious or enlarged lymph nodes nearby are usually removed and checked carefully during surgery. Micrometastasis is a concern.
Right. So surgery is the main treatment then?
Yes, surgical resection is the standard of care. The approach is often guided by the Shamblin classification.
Shamblin. What does that classify?
It categorizes the tumor based on its size and how involved it is with the carotid arteries, whether it's just sitting there, partially encasing them or fully encasing them. That helps plan the surgery.
And I see something about preoperative embolization, blocking the blood supply first.
Yes, for larger tumors, say Shamblin 2 or 3, there's often a debate about doing preoperative embolization, or PAE.
What's the thinking there? Make surgery easier? Less bleeding?
That's the idea. Reduce the blood flow to the tumor to make the operation safer and less bloody. But its actual benefit is still debated. Some studies show it helps, others not so much.
Okay. So not a clear-cut decision. What are the risks with the surgery itself?
The main concern is potential injury to those nearby cranial nerves we mentioned. The reported rates vary quite a bit in the literature, maybe 1% up to 30% depending on tumor size and surgical complexity.
That's a wide range.
It is. And some centers also report removing lymph nodes fairly often, maybe up to half the time, just to be thorough. But it's worth noting, historically, as centers gained more experience, the rates of complications like stroke have definitely improved. Experience matters here.
Makes sense for such a delicate area. Okay, so that covers tumors growing on the carotid body. Let's switch gears to something involving the carotid arteries function, Carotid Sinus Syndrome.
Right, Carotid Sinus Syndrome, or CSS. This one's all about the carotid sinus itself.
Which is like a sensor in the artery wall.
Exactly. It's a specialized area, a baroreceptor, located in the adventitia, the outer layer of the carotid bulb. That's the slightly widened part right near the bifurcation. It's packed with receptors that sense pressure.
And how does that sensing normally work? What's the pathway?
Well, these receptors respond to stretch or pressure changes in the artery wall. When pressure goes up, the sinus gets stretched, and it sends signals via the carotid sinus nerve, also called the nerve of Herring, a branch of the glossopharyngeal nerve, cranial nerve IX.
Got it, nerve IX.
Sends signals up to the brainstem. This activates the parasympathetic system, the rest and digest system, which tells the heart to slow down and blood vessels to relax, lowering blood pressure. It also inhibits the sympathetic fight-or-flight system.
Okay, a finely tuned reflex. So what happens in carotid sinus syndrome? Does it become jumpy?
That's a good way to put it. In carotid sinus hypersensitivity, CSH, or the full-blown syndrome, CSS, this reflex becomes oversensitive, hypersensitive. Even minimal pressure can trigger an exaggerated response.
And this causes fainting.
Yes, it's actually an under-recognized cause of recurrent syncope, fainting spells, and falls, especially in older adults. Aging itself seems to contribute, maybe making the baroreceptors less stable.
How common are we talking?
Surprisingly common. Some studies suggest hypersensitivity might be present in up to 45% of people aged 35-60, though many are asymptomatic. It seems more common in men, maybe a 4-to-1 ratio.
45%. Wow. But full-blown syndrome causing symptoms is less common.
Right. But when you look at older folks presenting with syncope, CSH is found in maybe 20% of them. And its prevalence increases with age and with general cardiovascular or neurogenic degeneration.
And it's linked to some neurodegenerative diseases too.
Yes, things like Parkinson's, Alzheimer's, Lewy body dementia. The thought is that the degeneration might affect the brain centers that process those baroreceptor signals.
Now, I see there are different types of this hypersensitivity. Cardioinhibitory, vasodepressor. What's the difference?
Good question. It depends on what the main exaggerated response is.
Yeah.
The most common, about 70-75%, is the cardioinhibitory type, CICSH. Here, the main problem is the heart rate dropping dramatically. You get ventricular pauses of 3 seconds or more, basically.
Yeah.
The heart stops beating for a few seconds, asystole.
Yikes. Okay, what's the next type?
That's the vasodepressor type, VDCSH. Much less common, maybe 5-10%. Here, the primary issue is a big drop in blood pressure, 50 millimeter Hg or more, without a significant slowing of the heart rate.
So blood pressure tanks, but heart rate stays okay?
Relatively speaking, yes. And then there's the mixed type, about 20-25% of cases where you get both a significant pause or slowing of the heart and a big drop in blood pressure.
And knowing the type helps guide treatment, I assume.
Absolutely. If it's mainly cardioinhibitory, you think about pacing. If it's
Mm.
mainly vasodepressor, you think more about medications or volume support. Or both if it's mixed.
So what's the underlying reason for this hyper response? Why does the system go haywire?
Well, the exact pathophysiology isn't totally nailed down. There are a couple of main theories. One suggests it's a central problem, maybe deterioration or lesions in the nucleus tractus solitari in the brainstem, where those signals are processed. The other theory points to peripheral issues, problems right at the carotid sinus baroreceptor itself, or potentially involving the nearby sternocleidomastoid muscle. Some evidence suggests that if that muscle loses its nerve supply, it might somehow lead to exaggerated sensitivity in the sinus.
Interesting. So how does this typically present? What should you look out for?
The classic presentation is a sudden onset of dizziness or syncope, usually short-lived, often with a quick recovery. Though if the BP drop is severe, recovery might take longer.
And falls in the elderly.
Yes, falls are a major sign in older adults, and sometimes they happen without a clear loss of consciousness, just a sudden weakness or dizziness leading to a fall. Some people might get a prodrome, like vision blurring or dimming, before they pass out.
Are there rarer symptoms?
Very rarely, people might report transient neurological symptoms, changes in their thinking, vision changes, numbness or tingling, even temporary weakness. But that's unusual.
What triggers an episode? Or does it just happen spontaneously?
It can be spontaneous, but sometimes there are specific triggers. Anything that puts pressure on the neck area, tight collars, necklaces, shaving over the carotid sinus, sudden head turning, even neck massage.
So simple things can set it off.
Yes. Also, compression from nearby masses, like tumors or lymph nodes, or sometimes changes after neck irradiation or surgery can make someone susceptible. But often, patients can't identify any specific trigger.
How do you diagnose it then, if it's often spontaneous?
Well, first you have to rule out all the other common causes of fainting and low blood pressure, dehydration, heart problems, medication side effects, etc. Standard stuff like blood work, EKG, maybe Holter monitoring, or even electrophysiologic testing. But the key diagnostic test is a monitored carotid sinus massage, or CSM.
Right, the massage test. How does that work safely?
It has to be done under controlled conditions, with continuous heart rate and blood pressure monitoring. The physician gently massages one carotid sinus, usually the right one first, for about 10 seconds, then stops, waits, and then does the left side. This is done both lying down and, importantly, standing up.
Why standing up?
Guidelines now suggest the upright position is actually more sensitive for picking up the vasodepressor component. A positive test is defined as that asystole of 3 seconds or more, or the blood pressure drop of 50 millimeter Hg or more, and reproduction of the patient's typical symptoms.
Reproducing the symptoms is key.
Yes. And sometimes atropine, a drug that blocks the parasympathetic response, is given to help differentiate the subtypes. It can block the heart rate slowing, but not necessarily the blood pressure drop.
Are there people who shouldn't have this test? Contraindications?
Definitely. You wouldn't do it if someone's had a recent stroke, TIA, or heart attack within the last 3 months.
And while just hearing a brute isn't an absolute no-no, having significant carotid stenosis, say over 70%, is a relative contraindication due to the small risk of dislodging plaque. Makes sense. Okay, so you've got the diagnosis. What's the treatment?
If someone's asymptomatic but found to have CSH on testing, usually just avoiding known triggers is enough. Educate them about tight collars, head movements, etc.
And for symptomatic patients?
Start with conservative measures. Ensure good hydration, maybe increase salt intake cautiously, avoid neck compression. If that's not enough, treatment depends on the subtype.
Okay, walk us through that vasodepressor type first.
For VD-CSH, increasing salt intake, maybe 6 U a day, and fluids is often the first step. But you have to be careful in patients with heart failure or hypertension. If that fails, medications might be tried. Alpha-adrenergic agonists like midodrine can help raise blood pressure. Mineralocorticoids like fludrocortisone can also help retain salt and water. Again, careful monitoring needed.
And for the cardioinhibitory or mixed types, where the heart rate drops significantly?
For CICSH or mixed type CSH, the mainstay of treatment is usually a pacemaker. Specifically, a dual-chamber pacemaker. DDD is preferred.
Why dual chamber?
It paces both the upper and lower chambers of the heart, providing more physiological support and generally better symptom control compared to single-chamber pacing in this context. Studies show it's pretty effective at reducing syncope.
Are there surgical options besides pacing?
They're much less common now. Historically, procedures like carotid sinus nerve denervation were tried basically cutting the nerve supply to the sinus, or even transecting the glossopharyngeal nerve or the sinus itself.
That sounds quite invasive.
Very. Glossopharyngeal nerve transection requires a craniotomy and has potential side effects like taste loss. It's really reserved for very refractory cases. Another surgical option is adventitial stripping.
Stripping the outer layer.
Yes, surgically removing that outer layer of the carotid artery containing the nerve endings at the bifurcation. It's complex surgery. Some early results look promising for symptom relief, but long-term data is limited, and there are risks like nerve injury or hematoma.
And irradiation, is that still done?
Carotid irradiation was tried in the past to sort of stun the nerve endings,
Yeah.
but its use is very limited now. The benefits were inconsistent, often delayed, and paradoxically, it's sometimes been linked to causing CSH in patients treated for neck tumors. So not really a go-to option.
Okay, quite a range of issues there. Let's shift now to moyamoya disease. The name itself is intriguing.
It is. Moya moya is Japanese for puff of smoke, and it perfectly describes the look on an angiogram, this hazy, abnormal network of tiny blood vessels that forms at the base of the brain.
A puff of smoke network. Why does that form?
It forms because the main arteries supplying the brain, specifically the internal carotid arteries as they enter the skull, and often the start of the middle and anterior cerebral arteries, become progressively narrowed or completely blocked. Moya moya disease is this chronic, idiopathic, meaning we don't know the exact cause and progressive condition.
So the puff of smoke vessels are the body trying to compensate.
Exactly. They're fragile collateral vessels trying to bypass the blockage. But because they're abnormal and fragile, they put patients at high risk for both ischemic strokes, due to lack of flow, and hemorrhagic strokes, due to bleeding from these weak vessels.
And this usually happens on both sides.
Yes, typically it's a bilateral process affecting the anterior circulation, the front parts of the brain.
Is it common
Yeah.
or geographically specific?
It's relatively rare overall, but significantly more common in East Asian populations: Japan, Korea, China, Taiwan.
Any idea why? Genetic factors.
Genetics definitely play a role, especially in familial cases, which make up about 10%. A specific gene, RNF213, has been strongly linked, particularly in East Asians. Having 2 copies of the mutated gene often means earlier onset and more severe disease. But most cases are still sporadic, without a known family link.
Interesting. You mentioned age distribution earlier.
Yes, it typically has a bimodal age distribution. One peak in childhood, around 5 to 15 years old, and another in adults, often in their 30s or 40s. It also tends to affect females more often than males, though there's some regional variation there too.
How does it present differently in kids versus adults?
In children, it often presents with ischemic symptoms, recurrent TIAs, maybe progressing to stroke. This can look like temporary weakness or numbness on one side, sometimes triggered by crying or hyperventilation. They might also have headaches, involuntary movements, or even progressive cognitive decline if the ischemia is ongoing.
And in adults?
Adults are more likely to present with intracranial hemorrhage, bleeding in the brain, either intracerebral, intraventricular, or subarachnoid. This can be sudden and catastrophic. They might also have ischemic symptoms, headaches, seizures, or dizziness, but hemorrhage is a major concern in the adult form.
What's actually happening to the main arteries? Why do they narrow?
The pathology shows progressive stenosis, or narrowing, of those terminal internal carotid arteries. There's a thickening of the inner layer, the intima, with smooth muscle cells accumulating. This eventually leads to blockage and reduced blood flow, causing hypoxia in the brain tissue.
And the moya vessels themselves, what are they like structurally?
They're quite abnormal. They have a thin middle layer, media, fibrin deposits, fragmented elastic fibers, and they're prone to forming microaneurysms, which contributes to the bleeding risk.
Is there an inflammatory component? You mentioned immune factors earlier.
There's growing evidence suggesting inflammation and maybe autoimmunity could play a role. Elevated levels of certain inflammatory markers and growth factors like VEGF, TGF-beta are often found in patients. These might contribute to the abnormal vessel remodeling and neovascularization.
How is it diagnosed definitively? Still angiography.
Cerebral angiography remains the gold standard. It directly visualizes the stenosis or occlusion of the main arteries and that classic puff of smoke collateral network. The Suzuki staging system, based on angiographic findings, helps classify the severity.
But non-invasive methods are used too.
Increasingly, yes, MRA and CTA are very useful for screening and diagnosis, especially with updated guidelines incorporating MRA findings. High-resolution MRI can also help visualize the vessel walls themselves.
What else could look like moya? the differential diagnosis?
You need to rule out other causes of intracranial stenosis, like severe atherosclerosis, vasculitis from autoimmune diseases, infections like meningitis, radiation-induced vasculopathy, or even brain tumors compressing vessels. There's also Moyamoya syndrome, where you see similar vascular changes, but they're associated with another known condition, like sickle cell disease or Down syndrome. Treatment is often similar, though.
Speaking of treatment, can you reverse the progression?
Unfortunately, no. There's no medical therapy that halts or reverses the underlying process of arterial narrowing. Things like steroids or calcium channel blockers haven't proven effective.
So what is the focus of medical management?
Primarily, it's about managing risk factors, controlling blood pressure, cholesterol, diabetes, stopping smoking. Avoiding triggers like hyperventilation is important, especially for kids. Antiplatelet therapy is controversial because of the bleeding risk, so it's used cautiously, maybe only if ischemic symptoms are severe. Oral contraceptives are often stopped.
What about surgery, revascularization?
Surgical revascularization is the main treatment strategy, especially for symptomatic patients or those showing progression. The goal is to improve blood flow to the brain to prevent future strokes, both ischemic and hemorrhagic.
And how is that done? You mentioned bypasses earlier.
Right, there are different techniques. The idea is to bring a better blood supply to the brain surface, bypassing the blocked internal carotid system. There's direct bypass, indirect bypass, or a combination.
Direct bypass, like connecting arteries directly.
Exactly. The most common is the STA-MCA bypass, connecting the superficial temporal artery from the scalp to a branch of the middle cerebral artery on the brain surface. It provides immediate flow improvement.
But technically demanding.
Yes. And it has potential complications like hyperperfusion injury if the flow increases too quickly. It might also ironically accelerate the blockage of the native ICA sometimes.
What about indirect bypass?
Indirect techniques involve placing well-vascularized tissue from the scalp or muscle directly onto the brain surface. Things like EDAS, encephalodurant arteriosyngiosis, or EMS, encephalomyosynangiosis. The idea is to encourage the gradual growth of new collateral vessels from that tissue into the brain angiogenesis.
Slower, but maybe safer.
Potentially less risky in terms of immediate complications like hyperperfusion, and technically less demanding. But the benefit is delayed, taking weeks or months to develop. It's often preferred in children.
And combined?
Combined, uses both a direct bypass for immediate improvement plus an indirect procedure for longer-term collateral development, often used for more unstable or acutely symptomatic patients. The overall goal is to normalize perfusion and protect the brain long-term.
Okay, a complex condition requiring tailored approaches. Let's move on to something that sounds a bit more mechanical. Carotid artery kinks and coils.
Right. These refer to variations in the shape or course of the internal carotid artery, ICA.
So not narrowing necessarily, but just bent out of shape.
Pretty much. Coiling is when the artery is elongated and redundant, forming an exaggerated S or C shape or even a full loop. Kinking is similar elongation, but with a sharp angular bend, often involving stenosis right at the kink.
Where do these come from? Are you born with them?
It could be either or both. There's a developmental theory. Maybe the artery doesn't straighten out properly as the neck elongates during growth. This is thought to be more common for coiling, but kinking especially is often considered acquired. It can develop later in life due to aging, hypertension, vessel wall degeneration like atherosclerosis, or maybe fibromuscular dysplasia, sometimes even after previous neck surgery.
So they can just be normal variations sometimes.
Yes, some degree of tortuosity or gentle curving can be perfectly normal. They become potentially significant when they're severe or associated with symptoms or stenosis.
How common are they, if they're often asymptomatic?
That's the tricky part. True incidence is unknown. Studies using imaging find them quite often. Arteriography reports range wildly, maybe 10% up to even 66% in some series, though that higher end likely includes mild curves. Duplex ultrasound studies suggest maybe around 25%, often finding kinking is most common, especially in older women.
And they can cause symptoms.
Yes. Even without significant stenosis, the altered blood flow dynamics within a sharp kink or a tight coil could potentially lead to clot formation and emboli traveling the brain. There's also the idea that severe kinking might cause temporary occlusion or reduced flow, especially with certain head movements, leading to TIA-like symptoms. And of course, atherosclerosis can develop preferentially at these points of turbulent flow.
So symptoms might not appear until later in life.
Often, yes. As atherosclerosis develops or the vessel wall changes further with age.
How do you diagnose them and decide if they need treatment?
Imaging is key. Again, duplex ultrasound is often the first step. CTA or MRA provide excellent anatomical detail, and angiography can be used, especially if intervention is planned.
And treatment if they're asymptomatic.
For asymptomatic kinks or coils, often just medical management with antiplatelets is recommended, similar to managing atherosclerosis risk.
But if they are causing clear symptoms related to that hemisphere,
Then surgical correction might be considered, especially if there's evidence of flow limitation or emboli originating from the kink coil itself, even without major plaque. A study by Bellotta suggested surgery was better than just antiplatelets for symptomatic patients without significant atheroma.
what does the surgery involve? Straightening it out.
Essentially, yes. The typical procedure involves detaching the ICA at its origin, trimming the excess length to eliminate the kink or coil, and then reattaching it, reimplantation, to the common carotid artery, sometimes slightly higher up.
Like tailoring a too long sleeve.
Exactly. For simpler kinks, sometimes a shortening angioplasty can be done. If there's associated narrowing or the lumen doesn't look right after straightening, they might widen the end, spatulation. For complex double kinks, resection and bypass might be needed, maybe using a vein graft.
And the outcomes.
Studies generally show good results, with low stroke rates after surgery and good long-term patency and relief of symptoms when performed for the right indications.
Okay, one last major area to cover intracranial vascular lesions, specifically stenosis and aneurysms. Why are these relevant for, say, a vascular surgeon focused on the neck?
Because the systems are connected, obviously, but also because patients might have both extracranial and intracranial disease, the risk factors overlap, and symptoms can sometimes be hard to pinpoint initially. Understanding the intracranial picture is crucial.
Let's start with intracranial arterial stenosis, ICAS.
Right, ICAS is narrowing of the large arteries inside the skull. Atherosclerosis is a very common cause, just like in the neck or coronary arteries.
But other causes too.
Yes, it can also result from emboli traveling from elsewhere, dissections, vasculitis, infections, radiation, sickle cell disease, even moyamoya disease involves intracranial stenosis.
How big a problem is ICAS?
It's a major cause of stroke globally and carries a high risk of recurrent stroke. Prevalence varies geographically. It's particularly high in Asian populations, maybe accounting for 30–50% of strokes in some regions, compared to maybe 5–10% in Caucasians. It's also significant in African American and Hispanic populations.
Risk factors similar to other atherosclerosis.
Mostly, yes. Hypertension, smoking, diabetes, dyslipidemia are key modifiable risks. Age, race, genetics are non-modifiable. Interestingly, one large trial sub-analysis suggested women with symptomatic ICS might have a higher risk of recurrent stroke or death than men.
How do you diagnose it reliably?
Catheter angiography, DSA, is still the gold standard for detail, but it has that small procedural risk. So it's often reserved for planning interventions. Non-invasive tests like transcranial Doppler, TCD, MRA, and CTA are widely used for screening and diagnosis. High-resolution MRI can even look at the vessel wall itself.
But non-invasive tests aren't perfect.
They're pretty good at ruling out severe stenosis if the test is negative, but their positive predictive value, how likely it is that stenosis is truly present if the test says it is, can be lower. Often a combination of tests is used.
And treatment, is it like carotid stenosis stenting?
Well, that's where it gets interesting. Medical therapy is the cornerstone aggressive management of risk factors, plus antiplatelet drugs, usually aspirin or clopidogrel. A major trial called WASID showed aspirin was just as good as warfarin. Another, Samprace, compared aggressive medical therapy alone versus medical therapy plus stenting with the wingspan stent.
And the result?
Surprisingly, aggressive medical therapy alone was found to be superior. The stenting group had a significantly higher rate of stroke or death within 30 days, mostly related to the procedure itself.
Wow, so stenting isn't the go-to.
Not anymore, not routinely. Based on Samprace, intracranial stenting for atherosclerotic IK is now generally reserved only for patients with very severe stenosis, 70–99%, who have recurrent strokes despite optimal medical therapy. Surgical bypass, ECIC bypass, also failed to show benefit in a large trial years ago. So aggressive medical management is really the primary approach.
Good to know. Okay, finally, intracranial aneurysms. What are the key things to understand?
These are bulges or dilations in the brain arteries, usually saccular or berry-shaped, often occurring at branching points. They're important because rupture causes subarachnoid hemorrhage, SAH, which is a devastating type of stroke.
What's these?
They're more common in women, typically found in people aged 35–60. Maybe 10–30% of people have multiple ones. Overall prevalence is around 2–3% in the general population. Risk factors include smoking, hypertension, certain genetic syndromes, and family history.
Family history is a factor here, too.
Yes, having 2 or more first-degree relatives with an aneurysm significantly increases your risk. And these familial aneurysms might rupture at smaller sizes. Screening with MRA or CTA is often recommended for those with a strong family history.
How do they present? Usually rupture.
Often, they're asymptomatic and found incidentally on imaging. But rupture is the big danger, causing that sudden, severe, worst headache of life, often with nausea, vomiting, stiff neck, loss of consciousness. Sometimes large, unruptured aneurysms can cause symptoms from pressing on nerves like double vision or pain.
Diagnosis and treatment.
CT scan usually detects the SAH if it's ruptured. MRI can be more sensitive for small amounts of blood. Angiography, DSA, CTA, or MRA is crucial to define the aneurysm's size, shape, location, and relationship to other vessels.
And treatment options, clip or coil.
For unruptured aneurysms, the decision to treat depends on balancing the rupture risk against the risks of treatment. Factors like size, location, posterior circulation is higher risk, patient age, family history, and aneurysm shape all play a role. Treatment options are generally surgical clipping, placing a metal clip across the neck of the aneurysm, or endovascular coiling, filling the aneurysm sac with platinum coils via catheter.
Is one better than the other?
It depends. The ICUA trial helped define rupture risks for unruptured aneurysms. For ruptured aneurysms, treatment is urgent. The ISAT trial showed endovascular coiling generally led to better long-term outcomes, less death or dependency, compared to clipping for many ruptured aneurysms, particularly those suitable for either approach. Other trials, like BRAT, suggested coiling might be particularly better for posterior circulation aneurysms, but the best approach is highly individualized.
A lot to consider for each patient.
Absolutely. It requires a multidisciplinary team and careful assessment of all the factors.
Well, this has been a fascinating journey through some of the less common but clearly important carotid and related intracranial conditions. Quite a diverse set of challenges beyond standard atherosclerosis.
It really highlights the complexity of vascular disease affecting the brain. It's not just about plaque.
And I think a key takeaway for you listening is just how crucial it is to consider these rarer possibilities in the differential diagnosis when someone presents with neurological symptoms. Getting the right diagnosis early can make a huge difference in preventing serious outcomes like stroke or major hemorrhage.
Definitely. Having these on your radar can really change the clinical approach.
So here's a final thought to leave you with. We're seeing incredible advances in imaging technology and our understanding of genetics. How do you think these advancements might change how we diagnose, understand, and maybe even treat these unusual carotid and intracranial conditions in the coming years?
That's the exciting part, isn't it? Better imaging might allow earlier detection, maybe even before symptoms, and understanding the genetic and molecular pathways could lead to targeted therapies we haven't even thought of yet. The landscape is definitely evolving.
Food for thought indeed. We hope this deep dive has shed some light on these complex conditions. If any particular one caught your interest, we certainly encourage you to explore it further. Thanks for joining us.